Hello class, page 24, year 4. The topic for today is School Oral Health Program. I am Dr. Abriza Ahmad. The content of the lecture will be in 4 parts, that is Introduction, School Oral Health Service in Malaysia, the difference between incremental and comprehensive care, and finally WHO Global Oral Health Initiatives. At the end of the lecture, it is hoped that students will be able to define School Oral Health Program, in short we call it SOHP, its objectives and advantages. Number 2, describe School Oral Health Programs in Malaysia, differentiate between incremental and comprehensive care, and finally, able to construct the strategies of WHO's Global School Health Initiative. School Health Program, that is SHP in general, refers to all the aspects of the total school program which contribute to the understanding, maintenance, and improvement of the health of the population, that is the school children and the staff of the school. The objectives are to enhance health awareness and skill building among the school children through healthy environment, disease prevention and health promotion, and also recognizing the child as a change agent in the family. Why the focus on school is that because the school has an ideal setting. It reaches to about 1 billion globally. The school supportive environment and moldable and influential stage of the children encompasses high-risk group, early opportunity of intervention, important link to the community, cheaper cost, easier reinforcement, and is less threatening. So, what is the importance of oral health? A poor oral health is detrimental effect on the child's performance and success in later life. Restricted activity if the child has a poor oral health and missing schools. Tooth decay and gum diseases are the most prevalent among children and will affect the early tooth loss. The effects of poor oral health also affects learning, general health, and the well-being. There will be poor nutrition, speech impairments, psychological problems, as well as other diseases, which is cardiovascular, diabetes, and cancer. The elements or components of a school oral health program is number 1, improving the school community relations by forming an advisory committee that should include the parents, teachers, school administrators, and dental professionals, as well as our counterpart in the health department and the community leaders. The task is to appraise and publicize dental needs of the school children, address the school administration's concern in the promotion of oral health, and to make people realize the importance of oral health. Number 2, conducting dental inspections. We can find the pros and cons when we do dental inspections, and serves as a basis for school oral health instruction, provide motivation to children for better oral health, baseline and cumulative data for evaluation, and provide the status of oral health needs for future planning. Number 3, conducting dental health education. This should include a suggested formal approach to teaching dental health in the classroom. Dentist serves as the expert resource person, and it's important to develop proper attitudes and personal dental health practices by teachers. There should be availability of dental health education kits at school. Number 4, performing specific programs such as toothbrushing programs, classroom-based programs which include fluoride mouth rinses and fluoride tablets, school water fluoridation, nutrition as part of school preventive dentistry program, sealant placement, as well as we have scientific fairs. Number 5, referral for dental care. If only emergency treatment is provided, referral should be made to the dentist. Blanket referral is sometimes used. We will talk about blanket referral after this. Follow-up, a good follow-up system is required and is usually handled by the dental therapist. So a blanket referral is actually a program that has proven to be effective in many schools. However, this is not implemented in the Ministry of Health. In this program, all children are given referral cards to take home and subsequently to their family dentist, who sign the card upon completion of examination, treatment, or both. The signed card are then returned to the school nurse or classroom, who plays an important role in following up the referrals with the child and the parents. The advantages of school oral health program. It is less threatening, permits health education, tackles simple needs, saving the complex problems to the specialized services, efficient method of referral to private care, ideal setting for auxiliary use, opportunity to young dentists. We have such a program in the Ministry of Health, which is a collaboration with the Health Department. It is also known as the Dr. Muda program. Peer-reviewed and integration with medical facilities. Limitations of school oral health program. There is often an unavailability of funds to begin or maintain the program, because a lot of funds are being shared for other services. Combating dental disease and training in personnel dental care are not part of the school responsibilities, so they leave it to the oral health personnel. The failure of the dental profession to handle emergencies and dental care for the poor and indigent, because there is no structured school or oral health program in the private sector, because the private sector is only on a fee for basis and based on demands of the patient. Preventive health education secures little support from organized dentistry, education, or government. Now we come to the second part, which is the school oral health service in Malaysia. The school dental health service in Malaysia is the main thrust of the public oral health services. Oral health is given to primary and secondary school children and is delivered through the school dental service, which utilizes incremental dental care approach. A systematic and comprehensive approach for delivery of care, with the final objective that the children achieve an orally fit status. The government dental services began as a school dental service with the training of dental nurses following the New Zealand style in the 1950s. There is the school oral health initiative is based on the concept of systematic and comprehensive care comprising promotive, preventive, and curative services. The focus is on prevention, early detection, and the control of oral diseases. Incremental dental care was introduced in 1985, and the Ministry of Health has come up with the Guideline of Oral Health Care for School Children, which was first published in 1997. The objective of the school oral health service is finally to achieve and maintain optimal oral health among school children, to render oral fitness amongst all school children who have received treatment, to strengthen clinical preventive initiatives, to enhance continuous professional development of oral health care providers, to empower school children in taking responsibility of their own oral health, to enhance the roles of teachers, parents, and the community in oral health promotion. So what do you mean by orally fit? It is what we call as free from active oral diseases. Ideally, it should be caries-free with DMFX equals 0 for 6 years old and DMFX equals 0 for 12 years old. So the percentage, you look at the percentage of no treatment required among 16 years old, case completion, and gingivitis-free, which is a good oral hygiene measure. In the school oral health service in Malaysia, we have the stages whereby there is planning, implementation, monitoring, and evaluation. So normally the state and the district management teams will do the planning, and they will collaborate with the Ministry of Education and other agencies. And in implementation, the delivery of care and monitoring is done at the state, the district level, and the progress is monitored through indicators stipulated in the quality assurance program. So we have the national indicator approach, district specific approach, the KPI or the key performance indicators, and the national oral health plan goals. And in evaluation, there is a utilization of resources for implementation has to be accounted for, and the improvement in the oral health among school children measured. The scope of the school dental service, we have an annual oral health examination, provision of comprehensive care, patient education, and care. There are a number of delivery modes. We have the school health education curriculum, school dental service, dental health education programs for trainee teachers, outreach initiatives, service for children with special needs, preschool service, fisher sealant program, toothbrushing program, and we have also got the blanket referral, which is not implemented in Malaysia. So these are the example modes of delivery. School dental clinic. It is established in the school in the 1970s. We have a room provided in the school by the school depending on the space availability, and will be equipped with 1 or 2 dental chairs and other necessary equipment. It's especially planned for schools with large enrollment. The advantage is that there is a proper infection control environment. So we have a team, either the dental therapists or the dental officers, the dental attendant, and also the driver. The incremental school dental service, it is in collaboration with the Ministry of Education of Malaysia. Next, we have the mobile dental team. Under this delivery system, the oral health personnel travel to the school by land or by river, depending on the location. And a temporary clinic is set up using appropriate equipment such as a portable autoclaves, portable dental units. The school will provide a suitable room for this purpose. And it serves to deliver oral health care to the rural and urban schools. So there are several types of mobile dental clinics. We have a mobile dental clinic attached to a prime mover or a bus or a van. The clinic houses 1 or 2 dental chairs and is fully aircon and equipped. Under the toothbrushing program, the school children are taught hands-on on the proper way of brushing teeth through toothbrushing drill. It can also be done without supervision of oral health personnel, because in some schools they do it as a routine after the lunch, after the break. In short, we call it LMG, which is the Malay version of toothbrushing, which is called latihan memberus gigi. It should be carried out on a daily basis or weekly basis, ideally. We have a school-based facial sealant program. This is a program aimed at preventing dental caries in permanent dentition among school children. It is implemented nationwide in 1999. Under this program, facial sealants are placed to tooth or teeth with deep fissures in children, especially those at risk for caries. And we have a guideline for reference. School-based fluoride mouth rinsing program is a means of controlling and preventing dental caries among school children, particularly in fluoride deficient or non-fluoridated areas. The fluoride mouth rinse is a fluoride solution intended for daily or weekly use where the fluoride is retained in dental plaque and saliva to help prevent dental caries. It is done in selected schools, and there is also the guideline which has been prepared by the Ministry of Health, Malaysia. Preschool dental service. This was launched in 1984 for what you call kindergartens. The program utilizes a friendly, non-invasive approach. So we want to introduce dentistry to the children via promotional and preventive initiative. So there is also the toothbrushing drill, puppet shows, role play, interactive games, and storytelling. In line with non-invasive approach, a traumatic restorative technique is adopted to provide restorative care for children based on indication. There is a program for children with special needs which was launched in 1993 with emphasis given to the disadvantaged group at outpatient clinics or at the institution. The objective is to improve their oral health and inculcate good oral health practices and increasing awareness to the carers of children with special needs. It is mostly emphasis on prevention. The curative component should subsequently be gradually increased in terms of types and complexity. Dental officers and dental therapists are the main providers, and the complex cases are referred to the specialists for further management. The pediatric dental specialists and the orthodontists in particular play an increasing important role in the management of complex cases. We have a program which is also known as KOTA, which is a program kesihatan oral tanpa amalan merokok. It is an initiative which started in 2016 with the objective of reducing the prevalence of smoking, and it targets the primary and the secondary school. The focus is on screening, prevention, and smoking intervention. The program for trainee dental teachers is launched in 1991 to create awareness and encourage participation of teachers in oral health promotion. The role of the teachers is to reinforce health messages and encourage oral health practices among school children. And cooperation of the teachers allow them to contribute effectively towards oral health care. The strategies for implementation. So we have the comprehensive oral health care for school children from primary 1 to form 5. strengthening of the referral system to dental officers and specialists, strengthening of the clinical prevention initiative, expansion of oral outreach initiative to increase coverage, enhancing continuous professional development of oral healthcare providers, enhancing the role of parents, teachers, community, and other activities. We have what we call as the National Oral Health Plan for Malaysia 2011 to 2020. There are a number of indicators and the goals are as shown. So it is hoped that the 2020 data will be out soon to make the comparison. In the National Health and Mobility Survey, NHMS, in 2017, it is found that 3 in 10 school children had caries and all the school children had gingival bleeding. Now we come to the third topic, which is incremental care and comprehensive care. Incremental care, or IDC, is defined as a periodic care, so space that increments of dental diseases are treated at the earliest time, consistent with proper diagnosis and operating efficiencies, in such a way there is no accumulation of oral health needs beyond the minimum. The criteria is effective, adequate, efficient, and appropriateness. So we hope to attain optimum oral health, maximum number of school children at the shortest possible time frame, and utilization of appropriate resources, technology, and health personnel. The advantages are that lesions of dental caries are treated before pulpal involvement. Periodontal disease is intercepted at or near the beginning. Topical and other preventive measures maintained on a periodic basis. Bills for dental services are equalized and regularly spaced. The program avoids the high expenditures of late dental care. It confines dental disease to small early increment, thus reducing loss of teeth, and inculcates a habit of periodic return to the dental office in subsequent years. The disadvantages: it is time consuming, attention to deciduous teeth, and interruption in the child's dental health program because there's mobility of children. So the difference between IDC and comprehensive dental care. In the comprehensive dental care, dentistry that is predictable and long-lasting usually involves a complete set of dental x-rays and digital photographs, periodontal measurements of probing, impressions and bite registration of teeth, and analysis of jaw joints and chewing muscles. It provides a full range of oral health services from diagnosis, treatment, follow-up, and rehab of the patients. So the differences when we compare is as below. As we know, incremental dental care is a periodic care which is spaced out. The increments of dental disease are treated at the earliest time. Whereas in comprehensive care, the periodic care is placed in mid-year base because normally people go for dental checkup twice a year. In incremental dental care, it is timely, so there is no accumulation of oral health needs beyond the minimum. Whereas the comprehensive care, it provides the full range of services, thus it is more expensive and it requires organizational work. Finally, we come to the WHO's Global School Health Initiative. The World Health Organization has identified key strategies for improving oral health with a focus on low-income, marginalized population where access to oral health care is most limited. These include strengthening both cost-effective population-wide prevention and patient-centered primary health care. So the work is being implemented through a 3-year roadmap And top priority is the development of a global oral health report, so as to provide evidence base for the oral health act. It is launched actually in 1995, which seeks to mobilize and strengthen the health promotion and education activities at local, national, regional, and global levels, designed to improve health of students, school personnel, families, and members of the community. It is guided by the Ottawa Charter for Health Promotion 1986, Jakarta Declaration of the Fourth International Conference on Health Promotion 1997, and the WHO's Expert Committee recommendation on comprehensive school health education and promotion. The goal is to increase the number of health promoting schools. So what is a health promoting school? A health promoting school is one that constantly strengthens its capacity as a healthy setting for living, learning, and working. It fosters health and learning with all the measures at its disposal, engages health and education officials, teachers, teachers unions, students, parents, the whole range of health providers and community leaders, in an effort to make the school a healthy place. It strives to provide a healthy environment, school education, and school health services. Besides that, there's also nutrition and food safety programs, opportunities for physical education and recreation, and programs for counseling, social support, and mental health. So, a health promoting school implements policies and practices that respect an individual's well-being and dignity, and provide multiple opportunities for success and acknowledge good efforts and intention as well as personal achievements. This is the Ottawa Charter and the Jakarta Declaration on Leading Health Promotion into the 21st century. So these are my references with the presentation based on WHO's and also Ministry of Health guidelines. That I thank you for your kind attention and wish batch 24 year for best of luck. Okay. Bye.